Again, I'd like to present a speaker who needs no introduction. I'd like to present Professor Dana Hartl from Gustave Roussy Institute. Did I say that right?
That was perfect.
Gustave Roussy in Paris. Dana?
Thank you. Thank you very much. I just really want to thank the organizing committee for this amazing meeting, for a great idea, and an occasion to get information and to make connections and meet up again at a more brief interval than every 4 years. So thank you for the honor of being here today. So I was asked to talk about lymph node dissection, indications and extent, and today we're talking about primary and recurrent, so I'm going to try to do it all in 20 minutes. Actually less, if I can get this thing moving. You all know this probably by heart. This is one of the tables from the American Thyroid Association recommendations. And as you can see here, that the lymph node involvement actually is a very important prognostic factor. And so it's actually very interesting to take this into account when you're going to classify patients into low risk, intermediate risk, or high risk patients for treatment and for follow-up. So I'm going to try to get this to work. So I'm going to talk about some definitions of central lateral compartments, a little bit about, tiny bit about pre-op workup, a few little tricks, and then definitions, extent of neck dissection, and then a little bit about reoperative surgery without going into technical considerations. So what's the central neck? It's called level 6, and it's actually the first lymph node basin that is involved in thyroid cancer. And there's prelaryngeal, pretracheal, and then either uni or bilateral paratracheal neck. So you can do unilateral, but you always have to remove the prelaryngeal and the pretracheal nodes. And there's a little trick you can do to not forget these Delphian nodes, these prelaryngeal nodes, is you can take those out when you're doing your thyroidectomy with the pyramidal lobe. You just go along down there, you go along the thyroid cartilage, you go along, this is for the surgeons in the room, sorry, you go along the thyroid cartilage and the cricothyroid membrane. So that's, you do that, you can do that right away before you're even thinking about the recurrent nerve. The lateral neck is most involved in levels 3 and 4, and then we'll look into a little bit of what to do with levels 1, 2, and 5. And these next levels have been widely adopted by the different surgical societies, and their definitions have been actually very well documented. So the central neck dissection is a comprehensive compartment-oriented removal of what we just saw, prelaryngeal, pretracheal, and paratracheal, at least on one side. So they see berry picking, and this is from the consensus statement from 2009, the Head and Neck Society. Berry picking is not recommended. And the finger technique, what's the finger technique? You go in and you palpate and you're like, okay, so this patient is N0. That's not very reliable. If I can get this through. The central neck is limited superior by the hyoid bone, so you really do have to go all the way up when you're taking down that pyramidal lobe. The innominate artery inferiorly and the carotid arteries laterally, and then behind you've got on the left the esophagus and on the right the prevertebral fascia. And all along in there, you've got the parathyroid glands, the current nerve, and I talked about, I put the thymic remnants on there too, because the thymus actually can be preserved in most cases. Of course, unless you've got metastatic disease that's right on the thymus, you're going to want to be resecting that. But in many cases, you can actually preserve the thymic remnant, and that will help you to find and maybe even preserve the inferior parathyroid gland. One thing also not to forget in the central neck is that the prevertebral fascia is deep to the recurrent nerve on the right, and so a lot of our colleagues forget to go back there. If you, for those of us who do parotid glands, it's kind of like doing a deep lobe of the parotid gland, so you want to get back behind that nerve on the right. Some have talked about, or some kind of the old literature talks about level 7. Level 7 was, because it's no longer a distinct entity in the new AGCC-UIC-CTNM. It was between the sternal notch and the brachiocephalic artery. And actually, in most cases, we know that most patients can actually, we can actually go down to the brachiocephalic artery from the neck pretty quickly, pretty easily, because this is just one study that we did looking at the distance between the sternal notch and the brachiocephalic artery for a patient in a normal position, not hyperextended, but a normal position for thyroid surgery. And actually, you've got about half of the patients where the brachiocephalic artery is actually in the neck. And then 95%, for 95% of the patients, it's only about 25 millimeters lower. So it's actually pretty easy to access. So level 7, you can forget. So what's the lateral neck dissection? It started out, gosh, more than 100 years ago for head and neck cancer, where we just got rid of everything except the carotid artery. And later on realized that this was functionally really quite difficult for patients to deal with. And so that little by little, surgeons realized that they could preserve the sternomastoid muscle, the spinal accessory nerve, and the jugular vein with oncologic safety. And this is for head and neck cancers. And then even more research, more studies actually, some retrospective studies that showed that this was safe. So the level of evidence for what we do today is not very high, but it seems to work, and that's what we're doing. But not high-level evidence. So using selective neck, and we realized that a lot of what we're removing could actually be saved and actually could help people live functionally in a much better, with higher quality of life. So I'm not going to go over the landmarks at all for just a tiny bit to say that to go over the neck dissection for level 2, you're going to go up to the digastric muscle. And level 2B, it's in yellow because if you can see the, got this little guy, you can, oops, I guess that's not going to work. You can see the spinal accessory nerve here that's going to be dissected completely and devascularized if you're going to do level 2B. So we'll get back to that because there is a risk if you're doing level 2A and 2B for the spinal accessory nerve. And just draw your attention also to the retractor next to the spinal accessory nerve that you really have to be very careful with this. We think about the recurrent nerve a lot. We're very, very, very careful about the recurrent nerve, but I think we should really be very, very, very careful about the spinal accessory nerve too. Let's see, sorry. And then just to say level 4, again, another nerve that's important, the phrenic nerve, and we're going to go down all the way to the level of the clavicle. Sorry. Just a little thing about, we were talking about head and neck cancer, but thyroid cancer is not quite the same, and neck dissection in thyroid cancer isn't quite the same, and I call them hidden lymph nodes for lack of a better term. Maybe somebody can find a better term for these little guys. But you've got lymph nodes that are sort of in between neck dissections. They're in zones that we don't go to often as head and neck surgeons. And you've got ones that are up here. They're lateral to the larynx. They're actually along the superior thyroid pedicle. And they're technically, I guess, level 6 because they're below the hyoid bone and medial to the carotid axis. But they're also kind of at the level of level 2, and they're sometimes even easier to access from level 2. So these are kind of in between 6 and 2, and you really need to look out for nodes in this, for metastatic nodes in this area. And then down below, it's a kind of an area behind the sternum, behind the clavicle that we're not actually really very familiar with, and you need to familiarize yourself with that area. And behind, we talked about behind the recurrent nerve, behind the carotid artery, around the innominate vein. So these are lymph nodes that can be forgotten or hidden or left behind if you're not savvy to what thyroid cancer does as compared to what head and neck cancer does. So just some examples of imaging, and finding these might need different kinds of imaging. This would probably be seen on ultrasound, but this, of course, won't. So what are we talking about when we're indicating surgery? We're going to be talking about therapeutic neck dissection. Even before you go in, you're like, okay, what am I going to do? I know this patient has metastatic nodes in the central compartment, so I'm going to be doing a therapeutic neck dissection in the central compartment or the lateral compartment. Prophylactic, or you'll also read in publications, elective neck dissection is performed in the absence of metastatic nodes. So you don't find any nodes, but you say, I'm going to go in, I'm going to do this prophylactically because I think there might be occult lymph node metastases, and I'll get back to that. The risk factors for lymph node metastases generally for papillary increases with the size and also with younger patients or older patients. Males, extrathyroid extension, even microscopic extrathyroid extension confers a little bit of higher risk for metastatic nodes, and then multifocal tumor. So I'm not going to read this recommendation, but just you really need to, before you go in for any thyroid cancer, need a really dedicated ultrasound lymph node mapping by somebody who looks for these, and looks for these hidden lymph nodes too. You need to work with a radiologist who's savvy to what thyroid cancer does and where thyroid cancer can go. And there are several publications and consensus statements giving the different criteria for suspicious lymph nodes, as you saw in one of the previous presentations. And cross-sectional imaging, well, why? If you have bulky nodes, it's kind of it's common sense-based medicine, not evidence-based medicine. But if you have bulky lymph nodes, if you have clinical suspicion of locally invasive disease, you're going to be wanting to do cross-sectional imaging with contrast. And I particularly like the CT scan because there's less motion artifact around the larynx in any case. And just a take-home message, I still see some CT scans without contrast because they think iodine injection is bad in thyroid cancer. You can inject iodine, and if you don't, you're just not even worth getting a scanner, okay? You see this is without iodine and with, and you can finally see where your vessels are and what's going on without and with. So when's that recommended? And I'm going to and again, this is based on, I tried to find the highest level evidence for this, and there are no prospective randomized studies that tell us who needs neck dissection and what. It's common sense-based medicine. This is what we do, and it seems to work. And then we've got expert opinion, which is great in the guidelines. And this is going to guide us, but we do need to think about that we don't have prospective randomized trials to really tell us what we're supposed to be doing here. But a lot of it's common sense-based medicine. So I started with medullary thyroid carcinoma because it's actually easier. Therapeutic neck dissection is recommended in medullary thyroid cancer, and prophylactic neck dissection as well is recommended. And this is based on the studies by Mackens and Drall and their team that showed a very nice continuum. As you see, calcitonin levels increase, the extent of lymph node involvement increases. And so, so we're going to guide our neck dissection according to, of course, ultrasound, but also the calcitonin levels. And so prophylactic neck dissection is really not that controversial in medullary thyroid cancer for patients who have calcitonin levels above 20. As we're going further, of course, the neck dissection is going to depend on whether this patient has metastases or not and how aggressive we're going to be in the neck. But these are patients up to 500 that we can cure by surgery, so we're going to be a little bit more aggressive. For papillary thyroid cancer, therapeutic neck dissection, again, these are strong recommendations, moderate quality evidence for patients who have evidence of disease. And then you have the question is how far. Level 1, that's the submandibular region, is not very frequently involved, and it's usually involved with patients who had, like you saw in that picture, really bulky nodes. So really, it's only if evidence of disease and without removal of the submandibular gland. And these are retrospective studies, so moderate, low-quality evidence, but this is what we do, and it works. Seems to work. Level 5 is kind of the same idea, not routine, only level of evidence. And sometimes, and often, you can just kind of extend level 4. You don't have to go and dissect the whole spinal accessory nerve. Level 2B, we talked about, again, not very frequent, and it's not routine. Eventually, if you have large nodes in level 2A, you might want to extend your dissection to level 2B. Okay, so how about prophylactic? She's finally going to talk about prophylactic neck dissection. So in the guidelines, they say central neck dissection should be considered when you've got lateral nodes and big tumors, and that's kind of that we're going to be a little bit aggressive with these patients in any case. Neck metastases in the central compartment are frequent when you've got lateral metastases, so we're going to be a little bit more aggressive surgically in general in these cases. But this is, again, low-level, moderate level evidence. What about low risk? What the guidelines say? Here, the American guidelines say that you can do prophylactic central neck dissection for T1, T2 if you're going to use that information to plan iodine or plan follow-up or something like that. But, and this is weak recommendation, low quality evidence. And then they say, but thyroidectomy without prophylactic neck dissection is also appropriate. And that's actually, you've got moderate quality evidence, but a very strong recommendation. So it's kind of, there's some expert opinion in there. It's not high-level evidence. So what's this based on? Okay, we all know that, I'm not going to go into this, high proportion of occult metastases in papillary thyroid carcinoma when we do these. But then, as you saw, the survival of low-risk cancer is identical to the general population. So why are we doing this? Well, it's sort of counterintuitive to say we know there's cancer in those lymph nodes, but we're going to leave them there. We're not going to do anything. We're not going to operate on them. We're not going to do iodine. And it's counterintuitive in cancer, but I think maybe that's what thyroid cancer does. We'll see. Anyway, so maybe it's better to improve local regional control, but then you've got a high rate of complications when we're doing it. And again, the survival is the same. And so there are thousands of these. I could have done 10 slides with these lists of studies saying, oh, it's good, it's not good, it's, I don't know. So there's this whole thing that goes back and forth. And this is the best level evidence we've got now, our meta-analyses. Being careful, though, because in these studies, there are microcarcinomas as well. But with and without neck dissection, 2 out of the 3 were significant. But if you look at the numbers, the difference between these two groups is 3.9 and 2.1%. So you're going to be actually overtreating. We see in these, if you look at these numbers, we're actually overtreating a certain number of patients if we're doing central neck. Well, are we going to ever get high-level evidence? I don't know. We're going to try. And in France, and I really want to thank everybody who participates in the French network, TUTIREF, and particularly thank Martin Schlumberger for leading us in that. And so there are 27 centers out of our network who are enrolling in a trial called Estimable 3. And it's a non-inferiority trial where we're comparing prophylactic neck dissection, not prophylactic neck dissection. And the main outcome is excellent response at 1 year. So we won't have the results for 2021, but we'll hopefully have some results at one time. I have 3 minutes, amazing. Okay, so reoperative surgery, just very quickly, I had a colleague who said, oh, well, can you come to talk to us about surgery in hostile territory? And I was like, what? I'm not, I'm not in the military. And they said, no, reoperatives. We want to know about this. And it's not the patients aren't hostile, but it's tough. It's difficult. And you've got more complications, so you have to inform the patients. And there's no guarantee of cure. So it's a big stressful situation for everybody. And I think there are actually 3 steps that I'd like you to consider. And don't try not to go to step 3 without going through step 1 and step 2. Make sure that's really cancer that you're going to go operate on. 2, really evaluate, and I would stress the importance of a multidisciplinary tumor board for going back in. And then, and I'm not going to get into the tumor mapping and the surgical planning because that's really complicated too. So really look at look at thyroglobulin in the washout fluid when you're doing cytology. If you think there might be metastatic disease, try to get that thyroglobulin because that can be very, very helpful. Again, you can use imaging, iodine, PET, DOPA for medullary. So that can really help you prove that you've got disease and see where it is. And then there's an American consensus statement, and Mark Erkin and his group wrote a really great article about the risks and benefits of going in. And you look at the size of the disease, how progressive it might be, the younger patients or older patients, what kind of risks, what kind of comorbidities. So we're looking at benefits. And I think soon, I hope soon, we'll have other non-surgical options as well, like radiofrequency, ethanol, redifferentiation protocols, stereotaxic body radiotherapy, and then even systemic treatments. So really, you need a multidisciplinary tumor board while you're thinking about going in. And I'm actually almost done. Thank you. Just briefly going in, If it hasn't been dissected before, well, that's great. You just go in and do your neck dissection. And if it has, you can just do targeted lymph node resection. Not berry picking. This is not berry picking. This is targeted resection, okay? And then, again, this is no guarantee for cure. And these are in order of publication. And the variability of results actually depends on what kind of cohort they were studying. If the patients had more aggressive pathology, high lymph node ratio, and lots of lymph nodes with extracapsular spread. But globally, it's about 2/3 of patients, 67 to 70% of patients that you are going to get an excellent result after reoperation. So in conclusion, neck involvement is very frequent. Therapeutic neck dissection should be compartment-oriented. Prophylactic neck dissection is recommended for medullary thyroid carcinoma because these are patients that we can cure surgically. But it's controversial for low risk, as you saw, and hopefully one day we'll have high-level evidence for low-risk patients. Really need to rely on your radiologists and on your tumor board, and I really want to thank you for your attention. Oh, no.